So to try to give you an idea how to develop liver biomarkers, I would like to start to kind of give you an idea how liver disease works, and kind of that you basically have two different processes going on in parallel. So and two different types of well-established biomarkers. So the classic biomarkers that we use in the clinic kind of on an everyday basis and used even by general practitioner and so on are the markers of acute injury. So these are the classic liver function test, ALT, AST, or GOT, GPT, whatever you want to call them. So this is basically a snapshot showing how lucky or how happy your liver is in a given moment. On the other hand, basically what the real problem in the liver is when an injury becomes sustained, and because of that you get a remodeling of the liver with increasing of scar tissue and development of what we call liver fibrosis and liver cirrhosis is the end stage. So these are really two somewhat different issues and having two somewhat different sets of biomarkers. Next slide. So as mentioned, the liver enzymes are the classic biomarkers. And here is a large population-based study showing how the normal liver enzymes look in the MMs, and that means in the normal population, and in the ZZs. And you see that they are actually not that different. So only 11 and 15% of ZZs have elevated ALT and AST levels. That means that a large amount of other ZZs have normal liver enzymes, and actually it remains quite unclear whether these patients are completely healthy. It doesn't seem to be the case. One back, please. Okay, and one of the issues is whether there are actually more sensitive markers of this acute liver injury. Next slide. So the big advantage of these biomarkers is that because they are kind of snapshots, that if we use an effective treatment, that we can of course change these biomarkers very quickly, and this is what we have shown in the previous talk. So for example, with this siRNA treatment, you get a normalization of these acute injury markers within a few weeks. And ideally, if you would use more than one marker, I think you would get a endpoint and a surrogate parameter, which could be quite useful in the FDA kind of battle. Next slide. I just wanted to mention another very well known very well-known marker from outside of the Alpha-1 world, and these are carnitine 18 fragments. And these have been evaluated in more than 200 liver-related manuscripts and show actually very nice correspondence to the liver histological findings, so to the liver inflammation and so on. And unfortunately, the data on Alpha-1 antitrypsin deficiency are very limited. So I believe that this is something we should look into and see whether we could potentially kind of stratify the population and get more than these 11 or 15% kind of abnormal ZZ patients. So the other part of liver injury biomarkers, as we said, are the liver fibrosis biomarkers. The reason why they are important is shown from this large study, which is not from Alpha-1, which is from another much more common disease called non-alcoholic fatty liver disease. And you can see that this increased liver scarring is clearly associated with increased liver mortality. So advanced liver fibrosis, which is here fibrosis stage 3 or 4, is associated with 6 times or 11 times increased liver mortality. So these biomarkers or this fibrosis is useful to get an idea with which patients are kind of at risk to develop a life-threatening liver disease. And there is a lot of different ways to measure the liver fibrosis. The gold standard is still the liver biopsy, which obviously is painful and kind of risky. There is tons of other potential surrogates. The ones which were studied the most in Alpha-1 are ultrasound-based surrogates of fibrosis, such as transient elastography. So these are the data on transient elastography from Virginia Clark's paper, and you can see that transient elastography, this is here called as VCTE, is the best biomarker to predict advanced liver fibrosis. So this is recognizing basically fibrosis grade 3 or higher. Some of the other well-known serum-based biomarkers, such as EPRI or gamma GT, which is more an injury marker, also show fair sensitivity to detect that. However, the issue here is that we are relatively good in detecting or excluding advanced fibrosis. We are not very good to discriminate between the intermediate fibrosis stages. So the problem with fibrosis is that this is a slowly developing process. And because of the fact that it's slowly developing, it's not easy to actually rescue it quickly. So as of now, there is in the liver universe, there is no established treatment which would show a reversal of liver fibrosis as a part of the clinical study. There is only one existing kind of published clinical trial which managed to improve the liver fibrosis, and this is again trial in non-alcoholic fatty liver disease that needed to analyze almost 1,000 patients and actually recruited almost 2,000 patients to basically show that you have a significant improvement in liver fibrosis. Here 23% versus 12%, but again 300 patients in per group, which are not numbers which we are likely to achieve in an Alpha-1 related trial. And also the time it took to kind of demonstrate this was 18 months, which again tells you a little bit something about how quickly we can approve drugs. So these are this was the first part which focused on the general ideas how to measure liver injury, both acute and chronic. And in the second part, I would like to talk a little bit about the AAT specific biomarkers. So the most obvious one is the amount of AAT retention. There are now several papers showing that the more fibrosis you have, the more AAT retention you have. And in line with that, if you have more retention of AAT in the liver, you are more likely to die. But again, the question is whether this is actually independent on a fibrosis stage or whether this is telling us basically the same thing as the fibrosis stage. Next slide. So obviously, even more attractive is to look at biomarkers which we don't need liver biopsy for. And one of the most kind of attractive ones is to measure the circulating Z-AAT polymers. There is a couple of data on this. A recent paper showing that the amount of AAT polymers in the serum may somehow correlate with surrogates of liver fibrosis. However, the correlation is quite weak. And as you can see here, this paper mixed ZZs with MZs, which is not a very clean approach. There are also some data from Jeff Techman and David Lomas that studied circulating Z-AAT polymers in children and could show that children with high polymer load are more likely to develop a decompensated liver disease with portal hypertension. And they showed that each increase in the polymer level increased the likelihood of this portal hypertension, which is a sign of advanced liver fibrosis by 7%. Another great piece of work which was done on AATD was to study extracellular vesicles, which is a special population secreted by all kinds of different cells. And the group of Mark Brantley showed that actually looking into the vesicles might be more sensitive than looking into the plasma. And for example, here they isolated the vesicles and looked at inflammatory cytokines such as TNF-alpha, and they could show that the ZZ patients with liver disease have increased inflammatory cytokines in the vesicles, but not in the plasma. And also the amount of the cytokines weakly associated with the amount of liver fibrosis. The problem here is that we don't have hard clinical endpoints. And also they use these vesicles to make a comprehensive analysis of microRNAs. These are short RNA pieces which are known to have a very nice prognostic relevance, and they show that several of these miRNAs are differentially produced in the ZZ patients compared to the MMs. So the conclusion so far from all these biomarker studies is that, of course, we can study all kinds of biomarkers, but the usefulness of the biomarkers will never be better than kind of the power of the patient cohorts that we have. And at the moment, we are still lacking well-characterized longitudinal patient cohorts. There are also other approaches one can take, which are more mechanistic. And for this, I think the kind of potentially useful therapeutic agents open us new windows. So these are our own data where we took the samples from patients before and 16 weeks after the initiation of the siRNA treatment. And if you look at the proteomic analysis, which is basically a holistic analysis of all abundant proteins seen in the serum, you see a major shift between the pre-treatment and post-treatment proteome, and there are several proteins, which most of them are actually involved in the acute phase response, that are clearly kind of normalized or improved after this treatment. And these approaches can actually also help us to identify specific proteins which are affected by this chronic prototoxic liver injury, as we see in the ZZ patients. That's it. Thanks a lot. Next slide. Oh, I have actually one summary slide. So again, there are acute injury markers. These are useful to get a quick overview about a potential efficacy of a new drug candidate, which will actually produce you much faster results compared to the chronic injury markers that will typically need years to really show any effect, even if the drug is useful. And I am a strong believer in omic approaches, and I guess Mark Brantley will say the same, and believe that these omic approaches that are double-checked with well-characterized historical cohorts can actually help us and can convince FDA about the efficacy of our treatments. Thanks a lot.
So I hope everyone can see that. Thanks very much, Pavel. So there's a lot to talk about regarding biomarkers when it comes to the lung disease associated with alpha-1 antitrypsin deficiency, and certainly 15 minutes won't cover it all. So today I'm going to focus primarily on molecular level biomarkers in the blood and in the lung. Before we get started, there's just my disclosure slide. Let's dive straight in and talk about the pros and cons of blood versus lung. And then at the very end, we'll discuss some future directions as well. And now, obviously, when it comes to any biomarker, the first question is, where do we look? And in a lot of respects, when it comes to alpha-1, the most attractive side is to go for the lung. Now, alpha-1 is a multi-system disorder, obviously, but if we want a marker of lung disease, generally speaking, we want it to come from the side of the insult. So when it comes to sampling the airway, we essentially have two choices, broadly speaking. We have bronchoalveolar lavage fluid and we have sputum. And bronchoalveolar lavage fluid, or BAL, is the current gold standard matrix for the assessment of airway inflammation, and in particular, neutrophil elastase activity, as Dr. Brantley mentioned earlier on. There are some drawbacks. It is invasive. It can be poorly tolerated by certain patients. It's costly from the point of view of running large multi-center studies. And also from the perspective of multi-center standardization, there's quite a degree of inter-operator variability. Furthermore, as patients get sicker, particularly with emphysema, bronchoalveolar lavage fluid becomes more technically difficult to obtain, at least research standard BAL. And that's because the airways in more pronounced emphysema become quite collapsible, and the volume instilled can very easily be lost in the distal airway with a poor return, very often not necessarily representing an alveolar type sample. Now, when it comes to sputum, sputum presents a less invasive means of sampling the airway, but inconsistent or poorly reproducible data between centers has been problematic. And the problems with sputum arise in part, again, from the acquisition, handling, and processing of the samples. In addition, there's also the possibility that sampling only patients who spontaneously expectorate sputum, or indeed who produce a lot of sputum to begin with, may result in a biased, sicker population, and in particular a bronchiectatic population, whereas relying on those who are fit for lavage may bias the population to a less sick cohort. And perhaps most importantly, numerous studies meeting biomarker endpoints for one have failed to do so in the other across the entire gamut of chronic lung diseases. So they meet an endpoint in lavage, but fail to do so in sputum, or vice versa. Now, there's always a bit of reluctance when it comes to blood to rely on blood biomarkers when it comes to lung disease. And that's understandable. Historically, they haven't correlated particularly well with outcomes, and many of them lack that specificity to the lung. On the other hand, blood-based samples are easy to obtain. Repeated sampling is acceptable. They tend to be durable in storage if you're talking about plasma supernatants, for example. And they can be standardized quite easily between centers as well. So if we hit on a good one, the upside can be tremendous, both in the trial setting and in the clinic as well. And there are obviously biomarkers that apply to COPD as a whole rather than being tailored specifically to Alpha-1. That doesn't necessarily mean that they're unuseful. These include neutrophil and eosinophil counts as phenotypic markers, non-specific markers of systemic inflammation like CRP and fibrinogen. CC16 and surfactant protein D were among the biomarkers investigated in ECLIPSE, and they do appear to be associated with disease severity and emphysema. Furthermore, they come from the lung, which is nice. And then there are a plethora of cytokines that have also been studied. IL-8 is a big one, IL-6 as well, as was mentioned earlier. Though it's becoming increasingly clear that certain phenotypes and indeed certain microbiomes will favor one cytokine profile over another. In terms of the more Alpha-1 specific biomarkers, we have a few options. Perhaps the most obvious is the Alpha-1 level. However, while levels have been shown to influence other biomarkers, the presence of a deficiency is in and of itself, from the point of view of lung disease anyway, not a particularly highly sensitive marker. And there are several reasons for this. The main one, obviously, is that many affected patients, i.e. patients who have a low level, remain quite healthy and have normal lung function. So that's the big problem with it. The second, obviously, is that the level and the antigenic level are two completely different things. And then the third is that the type of Alpha-1 being produced may behave differently. We heard Pavel talk about polymers earlier on, but also in terms of glycosylation profiles and receptor interactions, for example. Perhaps more useful is the genotype and indeed the phenotype. The degree of COPD risk in alpha-1 antitrypsin deficiency is related to the genotype. And as we and others have previously shown, the susceptibility to smoking-induced lung damage and the rate of decline in lung function in smokers with alpha-1 antitrypsin deficiency is again genotype dependent. Again, a simple blood test tells us a lot. So what about proteases? And this has been the focus of lung biomarker research in Alpha-1 for many years. The dogma, I suppose, is that neutrophil elastase drives lung disease in Alpha-1. NE is the most studied of all the proteases listed here. And I do worry somewhat that we might be a bit reluctant at times to challenge this. Historically, obviously, you could see how it came to be this way. Here we had a deficiency of a protein that was best known as the textbook inhibitor of NE. So it was taken that NE was the likely culprit of anything bad that followed. Now, the thing is that at that time, we didn't necessarily have as detailed a picture of the other things Alpha-1 regulated compared to what we know now. And indeed, without wishing to be overly controversial, I might suggest that we were wrong. And not necessarily about NE playing an important role in disease pathogenesis. I think it plays a very important role in disease pathogenesis for what it's worth, but rather our assumption that it was the only show in town, or that its key action was purely as a direct protease effect on elastin, for example. And there are a few reasons for this contention. The first is that at baseline, there isn't much by way of free neutrophil elastase, active neutrophil elastase in alpha-1 lavage. Now, granted, if, like me, you believe that unopposed NE activity during exacerbations is an important player in emphysema progression, then fair enough, we can partially explain this. But we have to consider also why it is that conditions with far higher NE activity levels, where the NE activity exceeds the protective screen, the protective capabilities of alpha-1, why these patients don't develop emphysema. And I'm referring to conditions like cystic fibrosis, primary ciliary dyskinesia, other types of severe bronchiectasis, for example. They don't develop this disease. Even within COPD, the NE burden is higher in chronic bronchitis, some would argue. Now, that again is not to suggest that NE can't be used as a biomarker in lung disease, but it may explain some of the difficulties with using NE to map disease progression in certain individuals with this condition. But in terms of assessing NE activity in alpha-1, what exactly can we do? How do we assess NE activity and then use it as a marker of, say, response to therapy, for example? Well, there isn't much of it in airway secretions at baseline, as we mentioned. Lavage in severe alpha-1 can be unreliable, as we mentioned. We often can't get sputum, and we can't go doing serial bronchoscopies in patients every time they have an exacerbation. And then there's also the concept of trying to measure the activity of something versus just the pure level of it. So some of the NE that is picked up, say, on an ELISA mightn't necessarily be fully active. We've been able to use FRET assays and other types of activity and performance assays. But again, that is a challenge when the absolute level in the airway isn't huge. So what about blood? Well, we don't necessarily pick up any activity in blood generally, but we do have some indirect measures of any activity, and they're listed there for you. The ones that we'll talk a little bit about are desmosine, isodesmosine, C3D, and first off, and we'll also talk about A-alpha valine 360 as well. But when it comes to desmosine, isodesmosine, we know that from rapid Olay that it changes in response to treatment. The best we've been able to do of late with regard to measuring elastin breakdown with desmosine, isodesmosine is seen in Michael Campus's paper on double dose augmentation. The main drawback to its use is that only certain centers obviously have the capacity to measure it. So from the point of view of integrating it into multi-center studies, that can be quite a challenge at times if there is an issue with access to the test. A-alpha valine 360 is an indirect measure of elastase activity that can be detected in blood and airway. It's specific to NE, which is great. That means it's a bioassay essentially for NE activity rather than for more general protease activity. Again, that's fine, and particularly if NE is the culprit. The double dose study also looked at A-alpha valine 360 and was able to capture a change in response to therapy. Our group in Dublin then has also looked at indirect measures of protease activity. In this example, we looked at complement and specifically complement C3 breakdown, and specifically emergence of the cleaved C3D fragment is associated with complement activation and drives inflammation. C3D is increased in alpha-1 in blood and lung. We found that it correlates with disease severity quite nicely, both in terms of spirometry and also the extent of emphysema in alpha-1 patients. And what's doing the cleavage? Well, we know that NE can, and that it does to a degree in the alpha-1 lung, but whether it is the sole culprit again in vivo is another matter. What about other serine proteases like proteinase 3 and cathepsin G? Well, in terms of proteinase 3, we think it's important, and I know our colleagues over in the United Kingdom agree with us. This slide is from an interesting paper by Robert Stockley's group looking at a PR3 specific product. This one's called A-alpha valine 541. It's a measure of PR3 activity. And their paper suggests that PR3 is actually more abundant or active than NE in the alpha-1 lung, potentially in certain patient groups anyway. In our group in Dublin, we're finding this is an important protease in cystic fibrosis also. So certainly something worth looking at in alpha-1 wheat field too. We also have to bear in mind that it's not quite as simple as the direct effect of NE on lung tissue integrity. What about the knock-on effects of NE on inflammation and on other proteases? So here's some work from Pat Garrity. Pat Garrity did this with our group. On the left, Pat showed that serine proteases upregulate expression of MMPs and cathepsins. He looked at MMP2 and cathepsin B, of course. There are other MMPs that get activated by neutrophil elastase. And then he showed that on the right, when you give alpha-1, you can modulate the activity of these proteases as well. So serine proteases are actually potentially pretty good indicators of inflammation, which is highly relevant to things like exacerbations in alpha-1 as well. We've looked at things like like altered glycosylation and its influence on both acute inflammation and resolution of infection, and the role of Alpha-1 as a modulator of IL-8 and LTB4. These are two of the most potent neutrophil chemoattractants in the CF lung. That's because our group in Dublin, while we would still work on protease, anti-protease a lot, we'd actually be inclined to view Alpha-1 more as an inflammatory lung disease, and one that also, for what it's worth, has an autoimmune component. We've also shown that Alpha-1 regulates autoimmunity and has strong anti-TNF properties. So when we're looking at markers of disease activity and active inflammation, these may be particularly helpful in Alpha-1. And there's, importantly, there's an interplay here. We know that, for example, IL-8 drives neutrophil chemotaxis, and that Alpha-1 regulates that process. We know that IL-1 drives IL-8, and that neutrophil elastase can drive IL-8 via TLR4 in the lung. We know that the neutrophils that come in after chemotaxing to IL-8 can spew out neutrophil elastase to trigger this. We know that TNF drives more TNF. We know that its receptor does as well. We know that that TNF can promote neutrophil degranulation and give you more neutrophil elastase. And we know that TNF and IL-1 then also drive IL-6. So there is a very nuanced interdependence among an awful lot of these cytokines. And this was borne out in the real world for us quite recently in Ireland. Here's some data from a group of patients we studied who were on long-term augmentation therapy and that then had their treatment discontinued abruptly. 10 years or so they were on this augmentation, and then it was stopped overnight essentially. These were very sick individuals, severely compromised lung function. We got really striking increases in these cytokines. Okay, so again, a big difference obviously between augmentation naive going on to therapy and particularly sick patients having treatment withdrawn, but quite striking increases. And again, event-based exacerbations in this group followed that pattern too. They more than tripled. Hospitalizations increased as well. So we think that these markers are quite relevant. Now, when it comes to interpreting these levels, we also have to be conscious that a level in isolation may not be a ton of use to us. COVID has taught us that when interpreting biomarkers, high isn't necessarily bad. Earlier on in one of the previous talks, it was mentioned that interleukin-6 is a big deal in COVID-19. I think one of the challenges early on in the pandemic was trying to convince people that it wasn't purely as simple as IL-6 is increased, IL-6 is pro-inflammatory, IL-6 must be doing the damage, and IL-6 must be bad. There can be good and bad for some of these cytokines. It's not as simple as just merely blanket inhibiting some of them. And we have to provide some context to how these cytokines work if we want to interpret them properly as biomarkers. You could argue, in fact, that with COVID and IL-6, we essentially fell into the same trap as we did for NE and Alpha-1. IL-6, as was mentioned earlier, is crucial for the acute phase response. It's also crucial for glycosylation of Alpha-1 into a more pro-resolution form, and silation of Alpha-1. When we treat liver cells of IL-6, we get Alpha-1 message and we get protein. Note the timeline as well. The timeline here is slightly delayed, so it is not something that you want to obliterate straight away. You need to give this acute phase response a chance to propagate. And here's that glycosylation that we were talking about again. This differentially glycosylated and silated form of alpha-1 antitrypsin, as seen in the right here, that emerges at times of acute inflammation to try and promote resolution. This has a greater affinity for IL-8, so it binds IL-8, it binds NAT2 as well. And this is triggered in response to IL-6, and it is suppressed to a degree by IL-10. And this all happens via an enzyme called ST6-GAL1. The overwhelming majority of alpha-1 is produced in the liver. This is a critical point because the majority of IL-6 signaling occurs via the liver as well. So IL-6 essentially it's produced in response to inflammation, but it signals via a fairly complex process. In order to achieve signal transduction, IL-6 has to first bind its cognate receptor, the IL-6 receptor. That's classically a membrane-bound receptor. The thing is that only certain cell types express the IL-6 receptor, most notably hepatocytes. Some immune cells like monocytes will do it as well. Now, for that signaling to actually take place, that complex then has to associate with another protein called GP130. And the thing is that GP130 is actually ubiquitously expressed. So all cell types will have GP130. And that presents an interesting conundrum because obviously in peacetime, so to speak, when inflammation is relatively under control, that means that IL-6 will act predominantly on the liver to generate an acute phase response. However, if there's something that can cleave that IL-6 receptor from the surface of the hepatocyte, and it floats off into the ether and can bind circulating IL-6, then that complex, that IL-6, soluble IL-6 receptor complex, can then associate with essentially any tissue it wants to, or any cell type it wants to. And that's when bad things start to happen a lot of the time. That latter process is known as trans-signaling. As a general rule of thumb, the physiological properties of IL-6, the protective ones, you might even say, tend to occur by the classic signaling pathway, whereas the aberrant, dysregulated inflammation that IL-6 is implicated in, that signaling, that pathological signaling, tends to take place via trans-signaling. And what dictates trans-signaling? Well, the cleavage does. And what's the cleavage carried out by ADAM17, which is a disintegrin and a metalloprotease, which we'll talk about in just a second. But again, the principle that I want to get across is that this is actually all about balance. It's all about the effect that the cytokine is having. This is far, far more important than the level itself. Really, to get a proper picture, we're talking about the cytokine level relative to the buffer designed to mitigate it, because soluble, or GP130 can become solubilized as well and form a buffer out in the blood. It's only when that becomes overcome that you get this trans-signaling kicking into any great degree. So it's about providing the correct context when we're interpreting a biomarker like a cytokine like IL-6. And all of this, again, the key determinant of all of this, all these pathological effects of IL-6 is ADAM17. So we might just talk a little bit about ADAM17, then we'll wrap it up. This is an elegant experiment, I think, presented in the Red Journal last year. The authors of this paper used emphysema-prone GP130 FF mice to illustrate the role of ADAM17 in the development of emphysema. We can see the FF mice develop emphysema after short-term exposure to cigarette smoke. That's in the top right of your screens there. But when you incorporate an ADAM17 deficiency into these mice, they don't develop emphysema, which I think is very, very interesting. Not only that, but in wild-type mice, cigarette smoke hyperphosphorylates ADAM17 and increases ADAM17 activity. ADAM17 is also the culprit when it comes to soluble TNF receptor 1. So you might recall from that earlier slide from our New England paper that we didn't look at TNF. We looked because TNF itself is quite a high turnover in blood. It can be notoriously unreliable to measure it in certain cases. The soluble receptor, on the other hand, is rather reliable and as a surrogate not just for TNF activity, but for pathologic TNF activity. Incidentally, Alpha-1 also inhibits TNF in several ways, not just by binding the receptor directly, but also by instituting essentially a negative feedback, because the TNF receptor and TNF itself will upregulate more TNF. Just trying to tie it back to all of these other cytokines, ADAM17 is also the key to neutrophil chemotaxis to IL-8. So it cleaves CD16B, also known as Fc gamma or 3B, from the surface of neutrophils. And without that key event, the neutrophils don't chemotax into the lung to IL-8. And again, just to reiterate, that's why panel F here, we went with soluble TNF receptor 1, because really what we were looking for essentially was a bioassay for alpha-1 activity. So what are we dealing with ADAM17? We're dealing with something that can modulate the effects of IL-6, can give us soluble TNF receptor 1 as a biomarker, can influence chemotaxis. It's detectable in blood and lung. It looks to have a role in emphysema progression, and wouldn't you know it then, it's also inhibited by alpha-1 antitrypsin. Here's work from Dave Bergen back in 2010 showing inhibition of ADAM17 by alpha-1. And note also, particularly in the panel on the right, the panel labeled D there, that different types of alpha-1 do this to different degrees. Again, highlighting the concept that the best biomarkers for alpha-1 lung disease are likely to be a little bit more subtle than just a level or a specific cytokine, and might instead involve things like the functionality of alpha-1 and the adequacy of the alpha-1 response to inflammation. So we're looking at these things like soluble TNF receptor 1 and the IL-6, soluble IL-6 receptor, soluble GP130 axis, as I said, bioassays, not necessarily of any activity or of a protease activity, but rather a loss of alpha-1 activity with that in mind. Anyway, I've spoken long enough. I'd be delighted to take any questions. So thank you for your time.
you so much. There are two that came in through the chat, so I'm going to go ahead and ask them. Pavel, what is the intra-observer and inter-observer repeatability of transient elastography? I am concerned about, sorry, somebody just put a new one in. I am concerned about this factor when getting reports from other centers.
Well, it's always the same. So first question is how well trained is the observer. So if the observer is well trained, then I would say, and also one thing which is important about that transient elastography is that it's basically like, it's a triage tool. So that means that you have like completely normal livers, which would be, let's say, fibroscan below 5 or 6. Then you have yellowish area, and then you have red area, which would be fibroscan above 9 or so. So if you have a skilled professional, you will have 85% kind of results which match on this semi-quantitative scale with some overlap. So that's how I would call it. It's by no means a quantitative measure like, for example, liver enzyme also.
Okay, thank you. What biomarkers should be used in clinical trials on AATD-associated liver disease?
Well, that depends whether you go for the really tough ones or the easy ones. So my belief is that and this is a political discussion, we have a monogenic disease where we understand the culprit of the disease, and when we are able to mechanistically tackle it, I believe that a omic approach showing a decrease in or reversal of the acute injury should be enough to get actually a conditional approval, and then you should be kind of forced to show the long-term efficacy data with reversibility of fibrosis and so on. So I would actually I would make the first step relatively simple, but demand a hard second step.
Okay, and then we have one more question before our next session begins, which is it easier?
Jeannie, I have a question. Yeah.
Oh, go ahead, Jeannie.
Oliver, I just wondering if you could comment on, you gave a really nice presentation about a lot of the proteases that are involved in the disease process, and I'm just wondering if you can comment on approaches that target these proteases other than Alpha-1 antitrypsin, and could these be methods by which we bring therapy forward? I know some of them are already out there, but can you comment on that?
So in terms of the potential efficacy, or in terms of how we'd monitor their effect?
Just what you think about that. What do you think about bringing other approaches to the disease, and you've shown the importance of these proteases?
Yeah, I think so. I think there are two ways to look at that. I think one is, can we specifically inhibit proteases that are shown to have a deleterious effect on Alpha-1 lung disease? The other way, I suppose, would be to look at, are there ways of us boosting our own endogenous responses to these therapies? And I think that really the elephant in the room when it comes to the anti-protease therapy we're all most familiar with in the form of augmentation therapy is that we're dealing with essentially a baseline supplementation rather than a dynamic response. I think that's a major drawback to it in principle, particularly if you subscribe to the thought that the exacerbations and the dysregulated immune response and inflammatory response to these infections is one of the reasons why people with Alpha-1 do develop accelerated early onset lung disease. So I think it may be a question of the timing of anti-protease therapy and finding a way of matching the supply to the demand.